this is going to be super interactive, so if you have questions, please ask. They asked me to talk a little bit about something different than neuro. Our goal, you guys, is to have a neuro conference, but to talk about other things in nursing that can have impacts on our care. So that's kind of why we're talking about abdominal pain today. What I want to do first, though, is I want to introduce you guys to a different type of assessment format that I think can be super helpful for you guys in taking care of your patients. As Dr. Rajpal alluded to, I was a paramedic for a long time, and this is a program that we're going to talk about that came from the paramedic realm of us who we don't have all these tests and we don't have all these CAT scans and stuff to kind of tell us what's going on with our patients. And that's a lot of you guys. Outside of ICU nurses, we have everything. We can tell you exactly what's going on with the patient because they have 700 monitors on, right? Well, you guys outside of that don't have everything. So what we're going to talk a little bit about today is kind of how to narrow down what do I need to worry about and how do I need to get there. And then when I call the doc, hey, I think this is what's going on with my patient. Not calling, hi, my patient's sick. Okay, that's not helpful because the doc's going to be like, can you give me more information? We're going to talk about how to get more information. So be prepared for the unexpected, okay? Hope that's not your car that got smashed because it was a long time ago. So you guys, what we're going to talk about is a topic called advanced medical life support. Have you guys heard of it? I know Terry has. So it's advanced medical life support, it's AMLS. And what it does, you guys, is it's a head-to-toe breakdown of a sick patient. Okay? So you walk into a room, what's going on with my patient? Do I need to act right away? Or do I have a few minutes to kind of figure out what's going on? Okay? You know if there's an ABC problem, we fix it. But what do we do once we get past that? So that's what we're going to talk about. The goal is to take EMTs and paramedics to say, gosh, my patient's complaining of chest pain. What does that mean to me? They have chest pain. I need to determine what's going on with this patient and what do I need to do. Okay? We're going to do some case reviews. Again, you guys, it's very hands-on, no wrong answers. Just tell me what you think and we'll go from there. So what's the first thing you do? You guys, you get your general impression. Have you guys heard that phrase before? You all do it. You walk into a room and you're like, oh, I'm going to lunch. I'll go to lunch a lot today. You guys will learn. A sick patient, I'm leaving. But what's going on with my patient? Do I have time or do I need to run and get a doc and get my coworkers? Okay? Or do I have time to say, hey, I have a few minutes, I can ask some questions? Okay? What's a Cardinal presentation? What do you think that is? Hi, this is Pam in the ER and I'm sending you a patient with abdominal pain. Okay? That's our Cardinal presentation. Do patients ever come in, they're admitted with, say, chest pain, and then you go in 6 hours later and they have, oh, my leg hurts, my belly hurts, and my head hurts. You didn't say that when you said when you were in the ER, but now they have different things, so our patients evolve. So how do we work through that? Okay? Figure out your life threats. Have you guys heard the OPQRST? Besides kindergarten, right? OPQRST. And then sampler. Okay? We're going to use these acronyms. You guys don't have to use them. They're just things to help you think about asking questions to your patients and what do I need to know. And then we're going to do some diagnostics. Okay? So your differential diagnosis. When you guys walk into a room and a patient says, I have chest pain, what do you think? Could be cardiac, okay? Could be belly, could be, and what about with abdominal pain? They have abdominal pain and you're like, oh crap. That could be 1,500 things, right? Anything that could kill them like a AAA, or it could just be the flu bug. So how do we determine what we need to do in between there? That's what we're going to talk about. That's your differential diagnosis. So when you walk into somebody's room, put all of those in a box. It could be one of these 15 things. They're on the call like, Mr. Jones, you have abdominal pain. Okay, here's my box of what it could be. Now I'm going to ask questions to figure it out. Oops, what's wrong? You guys walk into a room, everybody knows what a GI bleed smells like, right? Okay. UTI, right? Infection. Okay. What do you notice when you walk in the room? You guys, it's your scene present. What am I walking into? Okay. I'm walking to my patient on the floor. Okay, they fell. Cruddy, now what do I need to do? Or I walk into them, they didn't tell me they had a GI bleed, but that's what it smells like, so now I know what I have going on. Okay, I can work my way through that. So that's that little cow. What do you hear when you walk in the room? You guys, have you ever had a call light go off and then you walk into the room and it's dead silent? Does your heart hit the floor? You're like, oh, something bad is going on. It's all that. I think you guys do it all. It's just being aware of what you're seeing and what you're hearing and what you're smelling. Okay? Smell is the worst, though. It's our most refined sense, and you're like, oh, I didn't eat that one today. So So you guys, if there's a life threat, you treat it. You don't go any farther, okay? But if there's no life threats, then you can move on. So if there's an ABC, then you stop, pull the code button, and you get your team in there. If not, let's work through what else is going on, okay? Ask your patient, or ask yourself, is this person sick or not sick? Do we ever get patients that aren't really sick? Right? We had a lady in the ER the other day. She's like, I'll tell you I'm suicidal. I'm not. I just need a warm place to stay. But if you let me stay here, then I'll tell you I'm suicidal. Okay, well, that's unfortunate. She's not sick. Now we know what we need to work through. Versus walking into the room and your patient is dead silent or they're not breathing and something's really going on. Okay? It's as simple as that, sick or not sick. So that's what I want when you guys are walking through these case scenarios. Put it in your head. Are they sick or not sick? How much time do I have? What do you think about her, sick or not sick? Probably not sick, right? She's a little dramatic, but probably not sick. Do you guys have those patients? They should get Emmy Awards for acting that medications. So then you make your differential diagnosis. Okay, my patient has these complaints. I think she's not sick. So these are the things that could be going on with her. Okay? Versus, holy cow, they're halfway dead in the bed. They're definitely sick. I need to move quick. Okay? So now you do your detailed assessment. I have time. I don't have a super sick, life-threatening, sick or injured patient. I can do my assessment. So when I call the doc, I can say, these are their complaints, this is what they felt like, this is their vitals, this is what I saw with them going on. Okay? Doesn't that feel better than calling a doc? Dr. Rajpal, I have a sick patient. Can you come in? He's going to be like, Pam, I need some more information. Okay? This is how we get that information. Do your vital signs, and then assess your patient. Okay? And then we're going to talk about the OP, QRST, and sampler. These, again, are not things that you have to use. I just think they're helpful tools for me. So your O is your onset. When did it start? You guys have all gotten patients from the ER. We're like, oh, we just need to get them out. We only got one thing addressed, but they have lots of issues. They have a lot of comorbidities. You have chest pain, or you have abdominal pain. Tell me when that started. What were you doing? Okay, so that's your onset. You don't have to ask them, Mr. Jones, what was your onset? But you can. Okay? And then your P, your provocation. What's provocation? What's that? Somebody said it. What started it? What did you do? Okay, I fell down the stairs, or I ate some bad shrimp, or I just had this going on. And then, you know, because that will lead you down different paths. If they say, I have this tearing abdominal pain that started while I was sitting in my recliner, lots of red flags, versus I ate at some sketchy restaurant, and I don't know if it was any good, but I kept eating it, that leads you down a different path. Okay? What's quality? Character, yeah. What is it like? What does it do? What does it feel like? Okay? Radiation? Where's it go? Is that important? Absolutely, that's huge. Okay? Quality? That's kind of the, what is it like? That's again on that, what does it feel like? What does it do? What is the quality? What would you have to do to me to recreate this pain? Don't ask leading questions. Sally, are you having cramping pain? Okay, of course, I like that answer. What does your pain feel like? What would you have to do to me for me to experience the same kind of pain? Okay? And use your patient's words, you guys. Don't put words in their mouths, because then you're not going to get the assessment that you need. Severity is that 0 to 10. Okay? 0 is no pain, 10 is the worst pain you've ever had. Just because they say it's a 10 and you don't think it's a 10, it's still their 10, right? It's not our pain. Okay? And then time. How long has it been going on? Why is your time important? Is it important? Yeah. It's important because it gives you more information. Gosh, this just started, or oh, it's been going on for 3 months. There's your differentiation between sick and not sick. You guys get those 3-month patients? It's been going on for 4 years, 7 days, and 20 minutes. Good. I'm glad you're here. Let's fix it. Okay? So it's just important to know that information. So that's your OPQRST, and now your sample. Your sample is your signs and symptoms. What's a sign? Short of breath. I'm short of breath. Okay? That's more, I guess that's more of a symptom. Sign is something you can see. So I can see that they're pale. I can see that they're diaphoretic. Okay? But a symptom, I'm short of breath. I'm having nausea. I don't feel well. Okay? So signs and symptoms. Those are questions you're going to ask your patients. Allergies, is that important? Absolutely. And they might have an allergy band on. You might have to go to your computer. Just knowing, gosh, I need to know what they're allergic to. Medications. Do we care? A lot. Okay? What medicines are you on? Are they on chronic narcotics? Are they on ACE inhibitors? Are they on beta blockers? So let's say they should be tachycardic, but they couldn't be because they're on metoprolol. Okay? Asking about those meds, even if you think you know them, it's always a good question to ask. Okay? Pertinent medical history. Do our patients ever have anything else going on? No, right? They're always just perfect. They don't have CHF or COPD, asthma, anything, GERD, high cholesterol, hypertension. They all have these things. And have you guys ever gotten where, no, that's not a problem because I take meds for it? Okay, that's still a problem, and I need to know that, right? No, I don't have any medical problems. I take lisinopril and everything else. And that's a problem that I need to know about. When did they last eat? And for females, their last menstrual period. Okay, very important. You guys think that information might not be important, but it very well may be. So don't put it out of your questions to ask. And then the events leading up. What were they doing when the pain came on? That is the biggest thing. Because that's what we need to know. Is this person sick? Are they not sick? Do we have time or do we need to get on? Okay. So now we're going to put it to use. Maybe. Look at this. I think I froze your computer. What's that? Sorry. It's okay, I'll use this one. It's not a big deal. So you guys, how many organs are in the abdominal cavity? A lot. I'm sure there's more than we can count, right? So how many things can go? I know you guys are all like, oh shoot, she didn't tell me she's going to ask a question. Just think about how much is in there, okay? The brain, we got the brain, the chest, we got the lungs and the heart, we got a few other things that can go bad. But the belly, there is a lot that can go wrong in that, okay? So just understanding a little bit of pathophysiology, that's the goal of advanced medical life support. It's not to teach us what we need to do with the information, but it's what information you get. What do you do with the information when you have it? I know that this patient has this kind of pain, so what are we going to do with that? Okay? So we're going to talk about that. Associated symptoms. You guys, your patients aren't just a one-system functioning body, right? They have all kinds of stuff that can go wrong in all kinds of places. Ask them, get vital signs. Okay? Do you guys, vital signs, do they tell you anything about your patient? Nothing, right? You're like, oh, those are useless. No, they tell you everything. What's going on, okay? Do they have any GI bleeding? Are they nauseated? Okay? Any vomiting? What's their vomit look like? Do you have those people who bring you this bag and they're so excited, look, I want to show you. I don't want to see, but we need to see because if it's bloody versus just fluid-like or bile-like, then we know what we're dealing with a little bit better. Okay? Diarrhea, jaundice. Is jaundice ever good? Rarely, right? Okay? And then if they have any vaginal bleeding. Important questions to ask. Even if we think, gosh, this lady's 86. Important questions to ask regardless of their age. Okay? And then your life threats. You guys, is life-threatening? Internal bleeding can be life-threatening. Can you see it? Not very well, right? You need your vital signs in your assessment to tell you what's going on with your patient. Okay? Dehydration, you can kind of see dehydration, but can that get our patients in trouble in a big hurry? Absolutely. Okay? Sepsis? Oh yeah, that's a big national patient safety goal is sepsis identification. Okay, so you guys are going to see a lot about that. Extra-abdominal, like myocardial infarction. Have you guys seen women who come in complaining of belly pain and who are having big, huge MIs? Have you guys seen that? They don't have chest pain, they can't be having an infarct, right? Us girls, as the guys know, we do things differently, right? We do it. So we might have abdominal pain. We need to be aware, gosh, women can have abdominal pain, or men can have, and women, just shoulder pain. You know, somebody with shoulder pain, you're like, oh, go home, you work too hard. Well, we need to make sure we know that that's all that's going on. Okay? Metabolic disturbances, same thing. Renal. Your renal patients are sick. These patients are scary. Okay? So your anatomy. You guys, look at all this stuff in the belly. That's all the stuff that can go wrong. One slide, right? Just like that. So you guys, let's figure out. Look when you're doing your assessments, when you're palpating your patients. It sounds dumb, but know what's there and know what can go wrong. Okay? And then look at your presentation. Is it hollow organ? Is it solid organ? What are they complaining of? Those kind of things. And I know it sounds pretty silly, but it's really important. So we're going to talk about how you identify some of this stuff. Can kids tell you where their pain's at? Sometimes they can, if they're big enough, but sometimes they can't. Do you guys, anybody take care of kids? God bless those who do. Kids scare me because they have parents attached to them. I like the kids, but not parents. You guys who take care of kids, your assessment's harder because these kids aren't, they're just maybe lethargic. Gosh, are they sleepy? Should they be sleepy? Should they be eating? How much should they eat? Those are hard questions to gauge, okay? And then the elderly. Everything hurts. Okay, you push on their arm and their leg hurts because they've got such bad arthritis. Getting information from them. Tell me about your history. Well, in 1917, okay, no, I want today, or recently, so it's hard to gauge them down these paths of what's going on. So just knowing, it's a little bit harder to get information from some of these folks. But the assessment that you do, you guys, is where you're going to get your information. Okay? Have you guys heard of the 3 different types of pain? Do you know what they are? I mean, it's up there, but besides that, right? So you have visceral, somatic, or referred. Do you guys know that they all mean something different? Okay. Yeah? No? A little bit? All right. So what's visceral pain? Organ? What kind of organ? Hollow, right? Because it says that, right? Good. But you guys, that's your hollow organ pain, okay? So those muscles stretch and those receptors stretch, and that causes those people pain. That's why your appendicitis patients want to stay humped up, because that is saying, oh gosh, there's pain. So if you ask your patient to lay flat and they can't, what's going on with them? They have some kind of a hollow organ, something, okay? They're having some visceral pain. Gosh, that's a huge assessment. If you have these little kiddos who come in and they're walking hunched over, or your adults who are walking hunched over, you have a better clue of what's going on. You're like, oh, I think I know what your problem is, okay? Now I'm at least down a pathway and I can figure out what's going on. The problem with it is it's hard to localize, because you push here and then it may hurt someplace else, okay? So it's just things to know. Epigastric pain, it can arise from the stomach, the gallbladder, the liver, the duodenum. Again, belly pain is so difficult to figure out, so that's why we have to have such good assessments. So what's somatic pain? It's the opposite. This comes generally from nerve roots, and it's usually a little bit easier to figure out. I push here, it hurts. Okay? Sometimes easier, but still it can lead us down the wrong path. So it's really important to get more than one piece of information to help your patient. Okay? These are the patients who usually have that guarding or that rebound tenderness. No, don't touch there because it hurts. Because it really does hurt them. And so you know. Okay? What's referred pain? Besides scary. Right? You're like, why does your shoulder hurt when you're having chest pain? Okay. Referred pain. So you guys, let's look at what can be going on. Gosh, if your patient tells you they have right shoulder pain, does anybody get nervous about that? I was just in a bicycle accident, now my shoulder hurts. Okay, it could be your shoulder, it could be what else? What's that? Gallbladder, spleen. Okay, it could be 15 other things, so it's important to ask those questions. You might be like, oh, Mr. Jones, you have belly pain. Let's give you some Zofran, we're going to tuck you in bed and not worry about it. No, you can't do that. As nice as it seems, you want to go to lunch with me, right? But it's so super important to be like, okay, I have information and I have to do something with it. So here is some ideas of your referred pain. Okay? That's the same thing with women who have big, huge MIs and all they have is belly pain. That is so scary. These cute little old ladies come in. I'm just really nauseous and I have been for 2 days. The first thing they need is a 12-lead, right? Because are they having an MI? Same with our boys. Okay? Pneumonia. If you guys have patients who have back pain, and you're like, what does that have to do with anything? And they're having pancreatitis. Okay? You might be like, oh, you were shoveling snow, and leave it at that. Important to ask more questions. Don't just brush them off. Okay? So you guys, when you talk about pain and when you talk about your assessment, your list of differentials is as big as you can make it. Okay? Put everything in your bucket, and then you can take stuff out when stuff doesn't make sense. So that's what we're going to do as we go through today. I'm going to ask you guys to give me differentials. None of them are right and none of them are wrong. Okay, we'll just work through them. But just so you see, this is one page. All these things can go wrong with your patients, right? Are you glad you're a nurse? Woo, I get to figure this all out. So more, you guys, upper GI, lower GI, okay? What's going on with their kidneys? What's going on with their liver? All kinds of things that you can ask. So here's our first patient. You're a 72-year-old female who was a direct admit to your unit. Anybody going to lunch? It's lunchtime. Yeah, Terry's going to lunch. You guys, what do you think of her? With this information, what do you think? What's that? She looks sick, right? She looks kind of miserable. I would be concerned about her. I'd want more information. Okay. What are you going to ask her? Onset? Yeah. OPQRST. Okay. So here's your patient. You guys, you walk into the room, you find her lying in bed awake. She's got an IV and O2 in progress. You want your OPQRST questions, right? You want your samplers. Okay. So we'll talk about some of those. What do you guys think of her? What could be going on with this lady? She could be constipated, absolutely. Okay, that makes these little patients miserable, right? Okay. Does she have any immediate life threats? Anything that looks like it's going to kill her in the next 10 minutes? Not from what you can see, right? Fair enough, I would totally agree. Okay. Do you need more help? Do you need... I know my Longmont folks, we have a rapid response team. What about some of the folks from the other facilities? Do you guys have the same? Okay, so we'll talk about that a little bit as we go through. But do you guys need your rapid response team right now, and do you need to call your doc? No, you need some more time to figure out what's going on with the patient, right? Okay. What information do you need? We still need a whole lot more information, so let's find it. So what's her Cardinal presentation? Abdominal pain, right? That's because that's what we said, it was abdominal pain. Okay. What is in your differential box? What do you guys think? Give me 5 things that could be going on. You have a 72-year-old lady with abdominal pain. Gastroenteritis? Gallbladder? Absolutely. UTI? Very well so. Okay. Constipation? Yeah, one more? Pneumonia. Could be pneumonia or AAA, right? It absolutely could be a AAA. Okay. So you do your ABCs, your patient's talking to you. She has a breathing, she's breathing, that's always a good start, right? Her respiratory rate's about 16, and she's got weak radial pulses, and you notice her heart rate is fast. You guys got that in the first 30 seconds. You don't need your dash to tell you what her heart rate is. Feel her wrist. What does it feel like? Okay, is she pale? Is she clammy? She's fast. Now what does that tell you? Ooh, something's going on, right? You're like, okay, now I'm a little bit, still want more information, but there could be something going on with this lady. Okay, anything in the CNS? Could she have these CNS compromises? Maybe, but probably not, right? Could be. Okay, what about renal? Absolutely, right? She could have a UTI. She could be septic. Toxic medical. Do you think she's a weapons of mass destruction patient? Probably not. Okay, you never know. We're not here to judge, but could be. But medications. You guys, what medicines is she on? Could she have taken too many or not enough? Okay, absolutely. Sepsis. Anybody thinking maybe sepsis? Very easily could be septic, okay? Abdominal aneurysm, you guys mentioned that. That very well could be. We need more information, okay? Hopefully she's not pregnant, but again, we're not here to judge. But just keep that stuff in your box, okay? Upper GI, could she have upper GI stuff? Yep, she sure could. Okay, has she been nauseous? Is she vomiting? What's going on with her? Lower GI? Okay. Could she have like a peritonitis or something? Do you guys see how nice that is? You guys can be like, okay, this is the route that I'm going to go down. What's that, Ruth? Right? Yeah. Right. So it's just nice to be like, hey, I'm going to go down this path because I think this is what's going on. Okay. So now what do you want to know? What do you want to know? You want to do your sampler. Okay. So here's her signs and symptoms. She's been having right-sided abdominal pain for the last 2 days. It's worse today. She went to see her PCP. He was concerned for an appendicitis. Fair enough, right? Good questions. He had sent her over for further evaluation. She has pain that radiates into her right flank from her right lower quadrant. She's nauseated, she's weak, and she simply just feels bad. Kidney infection, right? Just like that. You guys figured it out, okay? She's not allergic to anything. She's on simvastatin, Plavix, and lisinopril. Her L is she ate lunch at 11:30, and no outside of her normal routines. What do you want? What kind of lab work do you want? What kind of more information do you guys want? Blood work? What kind? CBC? CMP? Chemistries? Okay. Does anybody want a lactate? Yeah? Okay. Procalcitonin? Maybe, maybe not. UA? Absolutely. Why do you want a UA? Because that's probably the source of her problem, right? Does anybody want blood cultures? You have to poke this poor lady. Okay. Yes, no? Maybe, yeah, she's running a fever. We need that information to judge. Okay. EKG, anybody? Pam said she's old and has belly pain. We should get an EKG. Absolutely. Okay. And she's tachycardic. Absolutely. Troponin? Sure. Why not, right? Okay. So you guys, here's your CBC. It's with the normal limits except her white blood cell count is 19.5. Ding, ding, ding. Big red truck, right? That she's got an infection somewhere. Okay. Her urine is positive for leukocytes, blood, and protein. What does she have? A UTI, right? Okay. Her chemistry's okay, except for her potassium's a little bit low. You guys, what is her lactate? Is that good or bad? That's bad. Why is it bad? It's too high. She's probably septic, right? That means there's some inflammation and some organs that are not being perfused because they're producing your lactate. Okay? So this woman is probably septic from what we guess is a UTI. Everything else looks pretty good. So now go back to your differentials. What did you guys put in? Okay, so bladder infection, pyelo, absolutely. Okay, sepsis, definitely, but you took out everything else just on doing an assessment and finding out some lab work. Okay. Again, hopefully she's not pregnant. Could she still have an appendicitis? She very well could, right? She's got an infection somewhere. It's probably in her urine, but who's to say that's not what's going on? So you do your head to toe. She's in some discomfort. Her neuro looks good. Her back is good, but she has this dull ache in her lower back. Now what do you think? Cystitis or a pyelonephritis, right? Okay. Her heart's regular with no murmurs. Are you guys good at heart tones? I need to follow you around if you are, because I'm not. Her lungs are clear. Why are your lung sounds important? What else could this lady have going on? She gets some pneumonia with her bladder infection that's been going on for who knows how long, right? So here's your EKG. Her glucose looks good, and her oxygen sat looks good. Right? Now what do you think? You have to call your doc and say, I think my patient has pyelonephritis, right? Okay? And you might not get this far before you call the doc, but if you guys can at least go down and anticipate, I know when the doc calls me, he's going to ask me for these 5 things. Okay? And that way you're like, oh, good, I was on the same path as you. Or I was totally off base. Tell me why you're thinking what you're thinking. Okay? So you're right. This lady has pyelonephritis. Just like that, you guys put it together. Okay? So it can be septic, or these patients can develop sepsis, and they can develop it very quickly. Think about this little 72-year-old lady. Maybe she doesn't have good hygiene habits, or even if she does, you know, what's her normal baseline? How well is she functioning? Okay? It may present with symptoms that are few or big and huge, like this lady was having. Okay? They may or may not have a fever. That's scary, right? I like fevers because they tell us that something's going on. But beware of a lack of fever too, just as aware as you are of a fever. And then when you tap on her back and she has that pain, then you know. Okay? So what are we going to do? Now we have this diagnosis. We have our patient with pyelo. What do? Lots of fluids. Give her some fluids, right? Okay. She might need some meds, some antipyretics. Get some more lab work if we didn't. Do you guys have sepsis protocols at your facilities? Does this lady warrant your sepsis protocol? Absolutely. So here's ours. You guys, your patients, if you're at Longmont and you're a patient, you have to meet 3 of these criteria to be considered a sepsis patient, okay? They have to have a suspected or confirmed infection. Does she have that? Yeah. At least in her urine, okay? So far, that's all we have. Her blood pressure is low. I didn't give that to you, but let's say it remained low after a couple liters of fluid. Okay? And then her lactate. What was her lactate? 7.1. So right there, she's septic, even without this information. And then she's got 2 or more of those inflammatory response systems, right? Because her white blood cell count was what? 19? Would she stay in your guys' unit, or would she go to the ICU where you're at? ICU, what about for you guys outside of yeah. Why? Yeah, she's going to go downhill probably quickly. Okay. But look at that. You guys took your abdominal pain, probably an appendicitis, to the ICU with a pyelonephritis diagnosis, right? Just like that, 5 minutes. But see how important your assessment is, and see how important it is to ask questions, and how goofy things in the belly can get in a big hurry, right? So, like we said, we'll send her to the ICU. You guys, our goals with this is our early management of these septic patients so we keep them from going downhill. But what did you guys just do in 5 minutes? You recognized that this lady's septic and you figured out from where. Okay? Just like that, using your AMLS, you got it. Okay? So getting that septic patients, getting them fixed up and keeping them safe is our goal. Okay? You guys want to do another one? All right. You know that's not right, right? All right, so you guys, here's your next patient. Do we have any ER nurses in here? I promise not to pick on you if everybody raises their hand. All right, so you guys, this is a 40-year-old lady who comes to the emergency department complaining of abdominal pain and vomiting. What's wrong with her? You're all like, oh, she's pregnant. Okay, that's a big deal. Or what else could be wrong? She could have pyelo. Her last lady did. Why can't she? Okay, so here's your patient. She's an awake female. She's sitting on the bathroom in her room, and she's presenting with abdominal pain. I feel sorry for her. I don't know about you guys. Right? I'm like, oh, you're having a bad day. But what do you think? Is she sick or not sick? She's sick, right? Yeah, there's something going on with her. Does she have any life threats? Not that we can see. She's sitting up. If she's sitting up, she's probably maintaining her own airway, and she's probably breathing, right? Who knows? She might have a low blood pressure, based on how compensatory she can be. Okay? So your primary survey, she's awake, she has an airway, she's tachypnic, so she's breathing a little fast. Do you guys breathe fast after you're done vomiting? I'd call my mommy, you know. So she's anxious. Okay, we'll give her that. She's got a great pulse at a rate of 102. She's a young lady. She can probably handle a heart rate of 102 for a long time. Okay? But that tells you what? She's got something going on, and we need to figure it out. Okay? So let's look at our differentials. Could she be something CNS? Could she have a head bleed? She's vomiting, right? And she's tachypnic. Absolutely. Okay. She very well could have a head bleed. We need more information. Could she have something renal-wise? Yep, absolutely. Okay. Probably, again, not poisons or weapons of mass destruction. Okay. Those are things you can... What about sepsis? Yeah. Her heart rate's only 102, but maybe she's a super athlete and her baseline heart rate's in the 50s to 60s. Okay. Things to be aware of. What about reproductive? Right. Do we know that she's not pregnant? No, we don't have that information yet. Definitely something we need to know. Okay. Could she have upper GI, lower GI, accessory organs? She'd have all that. Could she have an MI at age 40? I promise you she can. Okay. So here's her OP-QRST. She said it started suddenly. Nothing seems to make it better or worse. She's just baseline misery right now. Okay. It's a cramping pain, but it seems to be more constant. Okay. It radiates. It started in the epigastric area, but now it's in the right upper quadrant and radiates to her right shoulder. Okay. So now we want more information for sure, right? We're like, ooh, what's going on with her? Her severity is an 8. Do you believe her? Right. And she looks like she probably has a pretty decent pain tolerance, so I would buy her 8 for sure. It started an hour ago. So it's enough pain that she had pain that started an hour ago and she got right to the emergency room. Okay? And you guys will see two extremes. Either wait for 7 days or they come in right away. There's not a whole lot of middle ground there. Okay? So here's your sampler history. She's nausea and vomiting. She's allergic to penicillin. She doesn't take any meds. Her last menstrual period was 3 months ago. But she was at the doctor today and he said she's not pregnant. Okay? Could be. She ate 3 hours ago. She was sitting up and watching television and she tells you she's pregnant. Oh, good. Thank you. We don't have to go searching for that information. But we do have to double check that she's correct with her information, right? Okay. Now what do you think? Ectopic, right? How come? Pain? Sudden onset of pain. Is an ectopic a life-threatening emergency? Absolutely. Okay. All women of pregnant or childbearing age with abdominal pain are ectopic until proven otherwise. Have you guys heard that before? Definitely. But who's to say she doesn't walk into your unit and something goes wrong? Okay. So here, I'm going to give you your detailed assessment. Oh, there it goes. All right, so you guys, she has a temp of 99.3. Her heart rate's 102. Her blood pressure is 134/86. And her blood pressure looks pretty good, right, for her. I think that's a great blood pressure. She's awake, but she's lethargic. 40-year-old lethargic? Probably not right, right? Okay. Her pupils look good. She's got back pain that goes into the right shoulder blade. Huh. Sick or not sick? Sick, right? There's something going on with her. Okay. Which maybe before we're like, oh, you have the flu, you ate at that bad restaurant that you shouldn't eat at. Okay. Her abdomen is soft, but she guards her right upper quadrant when palpated. What's up there? Gallbladder? Could she have gallbladder problem? Yes. Yeah. Absolutely. Okay. Her skin is cool and clammy. Should she be cool and clammy? No, she shouldn't. Okay. And she's awake and alert with no neurodeficits. Good. We get an EKG because we're supposed to. That looks pretty good, right? We know that she's not having an MI. Her glucose is good. Her end-tidal CO2, most of us don't do that as a baseline anything, so. But that is normal. 35 to 45 is normal. So now what's in your bucket? Could she have cholangitis? Cholangitis? Yeah, you're like, sure, why not? Cholecystitis? Yeah. Absolutely. Gastric ulcer? Could be, right? Could she have an ectopic pregnancy? We said that already, right? That's more at the top of our differential than anything. Okay, food poisoning? Right. What do pregnant women do a lot? They're sick from eating anything, okay? Could she have a bowel perforation? Could be. So do you guys see how we took this big, huge list and we narrowed it down? Now what are we going to do? We're going to get some more information. So we want an ultrasound of her abdomen and pelvis. Why do we want that? Look for ectopic, and what else? Gallbladder. What's her gallbladder doing? Okay. Why do we want her liver enzymes? Gallbladder, right? Could she have a gallbladder? Sure could. And then a CBC. You guys want anything else? Pregnancy test, absolutely. Just to make sure. Okay, so she has an intrauterine pregnancy with a good fetal heartbeat. Yay! So she's pregnant with a successful pregnancy. Okay. Her liver enzymes are elevated. Can they do that in pregnancy? A little bit, yeah. Yeah, and she's got it. And her white blood cell count, though, is 11,000. Okay, what has she got going on? Something. What do you guys think her story is? Gallbladder, right? And you're right. So she has acute cholecystitis. Okay? What's that? She does need an ERCP. She needs to come visit you guys and get fixed up. So you guys, cholecystitis is more common in pregnant women. Okay? Everything slows down. They have a chance for those stones to build up. Okay? And they get that biliary stasis. And then same with our older patients too. Okay? So we went from, gosh, she could be having an ectopic, to she needs her gallbladder taken out, right? But that's okay. Look at how you guys moved down that path. You said you have a 40-year-old with abdominal pain who could be having 15 bad things going on, and maybe just a couple that aren't so horrible. Okay? So the pain usually begins in the epigastric area and radiates to the right upper quadrant. Okay? Silly, there's that radiating pain again, right? So asking your question and doing your assessments. It comes crampy at first, and then it becomes constant, and it may radiate to that right scapula. Why? Just the innervation of the nerves, right? Who would have thought this lady could have right shoulder pain and need her gallbladder taken out? Okay? Just things to be aware of. And then that Murphy sign, you guys, if she takes a deep breath and you push on her back and push over that gallbladder and she's got pain. That's one of those questions when you're taking those big fancy tests that they'll ask you and say you remember it. So what are we going to do? What do we do for her? Can you keep her on your unit? Yeah. Well, she's in the ER, so we'll send her wherever you guys are. But yeah, she can stay there. She needs pain management, right? Can she have pain management? Sure thing, right? This poor lady is in pain and we need to fix her. Oxygen if she needs it. IV fluid? Yeah, and she's probably a little bit dehydrated or baseline being pregnant anyway, right? Okay. Antiemetics? Absolutely. Okay, and then she may require surgery.
Being pregnant, are there any antiemetics you should avoid?
You know, in early pregnancy, I think most of them are pretty safe. Dr. Rajpal, is that antiemetics in pregnancy? Most of them are pretty safe, right? He's like, I don't care. He's like, I don't see pregnant. So do you guys, does that make sense? Do you like how that goes? It's just asking you questions and taking down your pathway. Okay, so now here's your last patient. You're caring for a patient who's admitted with flu-like symptoms yesterday, and now she's complaining of increasing abdominal pain. You're like, I wish it was shift change and it was time for me to go home. Did my bedside report, she hurts, I'm leaving. Okay, that's not where we're at. So here's your patient, you guys. She's a awake female found sitting in the chair, holding her abdomen and complaining of left lower quadrant abdominal pain. She's in moderate distress. Do you believe her? Yeah. She looks kind of sick, right? She doesn't look like she feels very well. Her cardinal presentation is abdominal pain. So she's awake, she has an airway, she's breathing, and her heart rate is 98. Again, maybe she should have that heart rate, maybe she shouldn't. I want more information. Life threats. Any of them? No? We have time to work, right? We can figure out what's going on with this lady. What do you guys put in your box of differentials? What could be going on with her? Diverticulitis? Somebody saw my slides, right? What else, you guys? Could she be the flu? Could she be pregnant? right? Okay. Could she be septic? Okay. Trauma? All of those things, you guys, we need to put into our differentials. Okay. Here's her OPQRST. She said it's a gradual onset. It's better if she doesn't move. Her pain is better if she, have you ever had those patients? Please don't touch me, please don't move me. Okay. What do you think about her pain? What's that? She's hunched over. So what kind of pain is it? Hollow organ, right? Because if you stretch her out, those stretch receptors, and she's like, oop, I'm going right back to where I'm comfortable. So she's got a hollow organ. How many hollow organs do you have in your belly? Like 110, right? All kinds of stuff. Okay, there's all kinds of stuff. Crampy pain, severity 7 out of 10. I believe her. She's got pain. We need to fix it. The pain's getting worse for the past few hours. What does that tell you? There's a process that's getting worse that's not improving. Okay? So she says she has some diarrhea with bleeding in her last stool. It was bright red. Okay? Now what are you guys thinking? GI bleed, diverticulitis, something relating to that. Okay? Would you have gotten that information had you not asked these questions? Probably not. Okay? She's not allergic to anything. She's on Plavix. Of course, right? And simvastatin. Oh, heck. Okay? So she doesn't have any history. Really, she had an MI 3 years ago, and she has a history of diverticulosis. Okay? So she's had an MI, that's why she's on these meds, and she's got this history. She ate breakfast at the hospital. How's our food? It's pretty good, right? And then she says she's just feeling cruddy for a couple days. Okay? She had diverticulitis on colonoscopy a year ago, but she's still taking her Plavix. Okay? Here's her assessment. Her temp is 100.2. Everything else looks pretty good. What do you think about her temp? She's probably got something going on, right? Everything else on your assessment looks good. Lungs are clear. Belly soft, except she has pain in that right lower quadrant when you palpate her. Huh, that doesn't make any sense, right? Could it be her appendix? Okay. Still, it could be diverticulitis, right? Absolutely. Okay. She doesn't have any neurodeficits. This is her EKG. Her glucose looks good. Now, what do you guys think is this lady's issue? I'm going to give you some hints. She an aneurysm? Probably not, right? Usually no fever, that kind of belly pain. Diverticulitis? Absolutely. Ovarian cyst? Very possibly. PID? Possibly. Absolutely. Okay. Endometriosis? Possibly, right? What do we need? We need an ultrasound or a CAT scan or something to tell us what's going on. Could she have a stone? Yeah. Usually those patients are in more pain, but she might just be stoic. Okay. IBS? Or GI bleed? What do you do for all of these things? Ultrasound, lab work, and treat her pain, right? Okay, so this lady, like you said, she's got diverticulitis. How did you know that? What pieces of information clued you in? Blood in the stool, the history. She's on blood thinners. Bless this poor little lady's heart, right? She's got a lot going on, okay? So, and she meets some of these risk factors. She's had diverticulosis. She's not, maybe she's chronically constipated, we don't know that, and she's not elderly. But she's got a history of it, and she has all of those pieces that hold it together. Now, when you first walked into her room, would you have been like, she's got diverticulosis? But when you ask these questions, then you can figure it out. Okay? So we just need, with diverticulitis, her pain is usually localized to the lower quadrants, which can skew us. We're like, ooh, is it an appy? What is going on? Is it ectopic? We need to know. Okay? She may have urinary symptoms. That kind of throws us off a little bit sometimes, huh? Okay, fever is common because things get inflamed, and she may have some peritonitis. Hopefully she doesn't, but she is at risk for that. Okay, and then we need a CT scan. Okay, whoops. So you guys, the abdominal cavity is huge. It contains all kinds of organs that can cause us anywhere from life-threatening stuff to I can go to lunch and figure it out later stuff. Okay. It's just super complicated with all these different kinds of pains that we can have. So it's really important to do a great assessment, figure out, does my patient have something that's going to kill them in the next 5 minutes, or do I have time to figure it out and make a phone call to the doc? Okay. Questions, you guys? Thoughts, concerns? Is that helpful? Yeah? Good. Let's have one little... oops. Oh, the turtle's on his All right. Well, thanks, you guys.